All right, I think it's almost time to get started. So I'll welcome everyone back for the third and final session of our symposium today. And in this session, we're going to go into how the motion analysis and modeling methods might be applied to understanding, studying interventions, or directly in clinical applications. And we have 5 presentations for that. I will remind everyone once again that we are recording. If any presenters do not wish their recording to be posted, please let us know. And with that, our first presentation in this session is from Arjan Lunen from the Netherlands. And he will be discussing a patient-specific model of titanium interbody cage and local strain patterns in the vertebral body. So, Arjan, take it away.
Yes, thanks for the nice introduction. These are my funding and disclosure statements. So, lumbar interbody fusion is an adequate treatment for a wide range of spinal disorders. And with this treatment, the intervertebral disc is being removed. An implant, what we also call an interbody cage, is being inserted between the vertebrae. And often this is combined with some supplemental instrumentation. And on the longer term, bony bridging should occur from one vertebrae via the cage to the other. However, in up to 20% of the interbody fusion treatments, this doesn't occur and it results in a non-union. And non-unions are generally related to inferior clinical outcome. And it is for this reason that new interbody cages are still being designed and introduced to the market. And one of those is this 3D printed truss titanium implant from the company Fullweb. And this interbody cage has this particular design as it may deliver mechanobiologically relevant strains to the attached cells and thereby affect the osteogenic response at the fusion site. However, this previous research was based on ex vivo, so laboratory tests. So the influence of patient-specific factors on these strains remains unknown. And therefore, the objective of this research is to determine the patient-specific variations in the local strain patterns on the surface on these kind of implants. And to do so, we make use of the MySpine patient database consisting of patients with lower back pain from the National Center for Spinal Disorders from Budapest. And a generic finite element model is morphed to the geometry of the patient, which was based on their MRI and CT scan. So here on the left, you can see the complete finite element model, which consists of linear elastic bone material, of which the exact parameters depend on the CT gray value of the particular patient. The intervertebral discs were modeled as poroelastic materials, of which the exact parameters depend on the Fehlman grade of, which was based on the MRI scan of the patient. The facet joints were modeled with surface-to-surface interactions, and the 7 major ligaments per spinal motion segment were included as non-linear unidirectional fibers. So this was, of course, the intact model, and we modified this one in order to simulate a posterior lumbar interbody fusion surgery. So what we can see here on the right is that we did a complete laminectomy. So we removed the complete spinous process, including the connecting ligaments. We implemented the pedicle screw rod construct, and 2 Fullweb PLIF cages were introduced in the interbody space using these orange contact layers, such that we didn't have to modify the bone mesh of the original models. The model started with a preconditioning step of 8 hours to allow the disc to the poroelastic disc to pre-swell, followed by a patient-specific follower load and a 20-degree extension flexion, while the follower load was increasing simultaneously. We did this for 4 different patients, of which we can see the characteristics over here. So first, we had a look at the low deflection curves, and we kind of saw the behavior that we expected. And the differences that we see in the patients likely originate from the patient-specific differences. So for example, the gray line and the blue line over here are actually from the patient with the least and most severely remaining degenerated discs. And also, if we look at the spinal motion segments, then we see some patient-specific variations. And one of the most interesting to highlight, I guess, are to say that these 3 discs over here were less degenerated than the one over here. And also these 2 discs over here were less degenerated than those 2 here, which conforms with a loss or a reduction of water and a decreasing intradiscal pressure in degenerating discs. But of course, we were mainly interested in what happened at the operated level. So here on the left, you can see the output of the strains on the cage for one particular patient. So in the neutral position, the strains are relatively small. And once we go into extension, the strains increase a little and shift posteriorly of the cage, while in flexion, the strains get even higher and shift towards the anterior side of the cage. And if we zoom in on this particular area, we can nicely see that these struts are actually bending inwards under the compression of the spine. So this was for one patient, and in order to compare the different patients, we quantified the amount of surface nodes that experienced an absolute strain over 200 microstrain. So here you can see how that differed between the different loading configurations, and we also have this 95% confidence interval between the different patients. So we can actually already see that the loading configuration had more influence on the percentage than the patient's specific factors. We did a similar thing for the contact pressure. So again, on the left, we see the pressure on the end plate for one specific patient, and in extension, again, this pressure is mainly shifting posteriorly and in flexion, of course, anteriorly. And the differences are not that much varying as for the surface strains, but in general, similar trends were shown. And to discuss these outcomes a little more, we saw that the patient-specific variations in surface strain and contact pressure were relatively small. So the maximum coefficient of variation in flexion was lower than 10%. But we also should mention that we had a rather homogeneous patient group, but we had chosen this on purpose because this allowed us to instrument all patients with the same cage size so that we didn't have to implement different heights or lengths of the cages. And 30% of the surface strains exceeded the value of 200 microstrain. And this value was actually chosen as it is a relevant value for preserving bone homeostasis. But it is worthwhile to mention that this value originates from bone remodeling research and not really about new bone growth in, let's say, a former intervertebral disc space. Additionally, we predict the surface strain with this mechanical model, and that we cannot translate it directly to what a cell would feel, because we would also take into account the influence of the roughness and the texture of the material. And we only looked at the situation directly after surgery, so new bone ingrowth is not included yet. And of course, it would also be interesting to look at other daily activities with a higher impact than only extension and flexion, but for example, also lifting weights or other higher impact activities. But overall, we think there's still a scope for design optimizations, and it will be interesting that we can optimize design such that we can target higher surface strains, or that we can realize that a larger percentage of the surface is experiencing a strain above the 200 microstrain. But of course, we should also keep an eye on the contact pressure, because we don't want to have a risk on subsidence. And we also still have to take into account that the implant can tolerate high peak forces, because it would be catastrophic if these cages will break when they are being implemented in the patients. And with that, I want to like to thank you for your attention and open the floor for questions.
Okay, thank you, Arjan. I think we have time for one question, and I see that Jaap Bondian has one. Let me see if we can unmute him.
Thank you, that works. Thank you, Arjan. I was wondering, I may have missed it, but how did you impose what boundary conditions did you impose? And specifically, did you account for any differences in muscle forces at the individual level?
So thank you for your question. In these models, we try to mimic the muscle forces by applying a follower load on the total spine. So in neutral position, this follower load between patients was about 400 newtons, and then while moving in extension, it increased to about 800, and while moving towards flexion, this follower load increases towards about 1000 newtons. But these the exact values were based on a previous literature or previous research. So that's how we try to implement the muscle forces as well.
Thank you.
All right, thank you. And I think in the interest of time that we will move on to our next presenter. So additional questions we will save for the end. Thank you. Our second presenter is Julian Mueller from Germany, and this presentation is about a biofeedback training on patients with nonspecific low back pain. And it looks like you're ready, so take it away. Did we lose her? I can't hear. Juliana, can you check your microphone maybe? So maybe because I'm not hearing the presenter, we should just go to the next presentation for and see if we can get the technical issue figured out in the meantime.
Yes, it's okay for me.
Okay. So so if Tito Bassani is ready to go, then we will move on to that one. So
okay.
I'll just hand it to you, and then we'll try to figure out the sound issue.
No problem. Okay.
Thank you.
Well, in adolescent idiopathic scoliosis, one of the major clinical challenges is the early detection of the curve progression, which can help in targeting the most effective non-operative treatments. And in this regard, in the last years, predictive models accounting for geometrical parameters of the spinal alignment have been developed, trying to predict the curve progression in mild scoliosis and before the growth part. So in this context, the question is, could biomechanical measures, in this case provided by musculoskeletal modeling, represent advantageous additional information? We evaluated the data set of 100 scoliotic subjects underwent to EOS radiographic examination at first visit and identified as mild scoliotic by the Cobb angle and before the growth part by the Reiser sign, which is a measurement of the state of ossification of the iliac apophysis. And the subjects were recognized after a follow-up period of minimum 6 months as stable or progressive, depending on the increase of Cobb angle below or over the 10 degrees and depending on the state of skeletal maturity. The radiographic images were processed by stereo software, allowing for obtaining the geometrical measurements, and the obtained orientation of the vertebral orientation in the 3 anatomical planes were processed to obtain the replication of the spinal alignment with the musculoskeletal body model with the articulated rib cage and previously validated for the replication of mild scoliosis. And the simulation run by Antibody allowed to obtain the biomechanical outcomes, the intervertebral reaction force, and the muscle activation at each vertebral level of the erector spinae and multifidus muscles. So we evaluated anthropometrical parameters such as age, sex, and the Reiser sign at first examination, the 9 geometrical parameters of the sagittal and spinopelvic alignment, as well as the number of scoliotic curves and the geometrical parameters of the 3D shape of the primary scoliotic curve, the Lenke type as well, defining the classification depending on the number of curves and location. And in addition, the 11 biomechanical parameters, in specifically the intervertebral lateral shear at 3 levels of the primary scoliotic curve, the apex, the upper and the lower end, and the normalized muscle activity ratio of the erector spinae and the multifidus, which is a measure of the balancing of activation of trunk muscles. And in particular, it reaches values of 0 in case of a balancing activity, and ranges between -1 and +1 in case of larger activation in the convex or the concave side. Let me show you the result of the average values of these parameters in stable and progressive groups. The statistical significance is indicated by colored cells. And as you can see, only the age and the Reiser sign were found different in progressive cases, lower specifically, indicating what is already known from literature, that the earlier is the onset of scoliosis and the higher is the probability that the deformity will increase. The geometrical parameters were similar between the 2 groups, actually, and only the intervertebral lateral shear as regards the biomechanical parameters were larger in the stable group, and this is related to the higher Cobb angle, the higher Cobb angle found here in the stable group compared to the progressive that was not significant in any case. As you can see from the right panel here, the intervertebral force vector tends to be generally vertically oriented, even if in case of a deformity. And for this reason, a larger deformity implies a larger orientation of the vertebrae in the frontal plane, and thus a larger contribution in the lateral shear as found here. And about the muscle activation, they were found generally slightly larger, indicating a larger activation in the convex side, and confirming what already known from literature about the scoliotic cases. When we evaluated the effect of accounting for the biomechanical parameters on the prediction of scoliosis progression, we defined two sets of predictors. The reduced set, which accounted for the 12 predictors, the 3 anthropometrical and the 9 geometrical, and the full set, which accounted in addition for the 11 biomechanical parameters. So we arranged the 2 consecutive phases. In the first phase, the preselection, we compared 6 different algorithms for the binary classification of stable and progressive subjects. And we recognize as the best fitting ones those providing the largest accuracy by repeated cross-validation procedure. In the second phase, the comparison one, we computed the sensitivity and specificity, and we compared this classification performance between the reduced and the full predictor set. Specifically, we randomly split the original data set in 2 subsets of training and test set. The first one we used to estimate the model parameters, and the test set to compute the sensitivity and specificity. We repeated the operation for 100 times, and we compared the median average value. The results of the preselection phase demonstrated that 3 in the 6 evaluated algorithms provided larger accuracy, also in statistical perspective, and specifically PDA, Bay, and ENS algorithms were used in the second phase, in the second subsequent phase, the comparison one, to compare sensitivity and specificity, which pointed out that basically the median values were very, very similar between reduced and full set, so demonstrating that the unexpected results that accounting or neglecting for the biomechanical parameters provide very, very similar values of sensitivity and specificity. The take-home message is that in the evaluated condition, which are mild scoliosis and replication of the static standing posture, the information from musculoskeletal simulation basically reflect those provided by the geometrical reconstruction without representing an additional advantages contribution. And for this reason, a potential clinical application is not supported at this time. As regards the limitation, the main one is that the information about the recent treatment that is recognized to contract the progression of the curve were not available. But the inclusion criteria, which were the Cobb angle was lower than 25 degrees, and the condition that the similar average follow-up time was found between stable and progressive group reduced this probability of potential biasing. Moreover, the data set exploited accounted for a moderate number of subjects, 100, and a larger data set should be used to better refine the classification models and to support the results. And thanks for your attention.
Thank you, Tito. And we will take a moment for questions and maybe then see if Juliana can be heard now. So if looks like we have one question in the chat, and I'll just read it for expediency. When considering biomechanical parameters used to define the muscles, did you use parameters from healthy subjects? And would you expect AIS subjects to have different parameters? And related to this, were passive properties of the muscles considered?
Well, if I correctly understood the question, is about considering how muscle parameters could be in healthy subjects compared to scoliotic ones. Is correct?
I believe so.
Okay. Well, we have to consider that. Let me. Okay. We, as regards the musculoskeletal models, we scaled the cross-section area of the trunk muscles by accounting for reference values depending on age. And in my opinion, I think that the only difference here is about the activation between the convex and the concave side. So we found in preceding studies, both from in vivo measurement from EMG recordings and also from musculoskeletal simulations in mild, moderate, and severe scoliosis, that there is a difference between the activation in the convex and concave side, which will be not found in healthy subjects. So basically, in healthy subjects, the parameters will exhibit a balanced activation between the two sides. So I think that this would be the only main difference between reference healthy values and the scoliotic ones.
Okay. Well, thank you. Let's move on, as we are now running a little behind. Julian, can you be heard?
Hello, everybody. Do you hear me now?
Yes, we do. Excellent.
I'm really sorry for this problem. I don't know why, but okay, I'm happy it works now.
All right, so we'll turn it over to you for your talk.
Thank you. Yeah, we'd like to thank all of you organizers for the possibility to present our research focusing on interventional effects of exergames on trunk motion in the context of low back pain. As it is evident, patients with chronic non-specific low back pain show reduced range of motion as well as reduced proprioception compared to asymptomatic persons. Thus, improving movement control might be a promising treatment goal for chronic low back pain rehabilitation. However, some sort of external biofeedback is required for this therapy approach, and new health technologies, an example, sensor-based exergames, might be able to provide reliable real-time feedback in combination with game-based tasks, and therefore are favorable for this therapy approach. Therefore, the purpose of our study was to evaluate the acute effects of a single bout of game-based real-time feedback intervention on trunk movement and control in patients with chronic low back pain. In our study, we included 13 chronic low back pain patients, 5 males and 8 females. The anthropometric details are presented in the table. Our study was conducted in a randomized crossover trial with 2 arms, 2 different periods, intervention and rest period, as presented in our flowchart. The study included 3 measurement points, M1, M2, and M3, and 1 intervention and 1 rest period for each participant. 1 measurement day took about 2 hours for 1 participant. Our measurement protocol started with the assessment of the anthropometric data. Secondly, participants were prepared for kinematic analysis of the trunk and its motion. Afterwards, the assessment of trunk motion during lateral reflection while upright standing was conducted. And we first concentrated on measuring the range of motion and focusing on the maximum angle in lateral reflection for left and right side. And secondly, the angle reproduction was assessed by focusing on a target movement angle of 20-degree lateral reflection. Each subject had 2 familiarization trials and 10 repetition trials that were measured for each side. This was then followed by the intervention or rest period in randomized order. And step 3 is identical for all 3 measurement time points. Trunk motion was measured with an optical 3D motion analysis system, and the Riesoli trunk model was applied for tracking multi-segment trunk kinematics. Therefore, 15 markers were used to frame 2 segments, a thoracic segment and a lumbar segment, as shown in the figure. In addition, the whole trunk was analyzed as the sum of the 2 segments. Taking a look at our data analysis and main outcomes, the main outcome measures were the maximum angle in lateral reflection for the main movement plane. This was here the lateral reflection, but we also analyzed the angle in the evasive motion in the secondary movement planes, so the rotation and extension flexion movement. In addition, the individual angle reproduction was analyzed for trunk lateral reflection. We had a target angle of 20 degrees and Therefore, the mean value out of the 2 preparation trials was calculated as a reference value, and then the mean difference between the 10 repetitions to this reference value was calculated and normalized. The statistical analysis was a 2-step. Firstly, we measured the data. Firstly, the measured data were analyzed for a potential carryover effect between the 2 crossover periods, so the rest and the intervention period. And secondly, before to after intervention data were matched and analyzed by one-way analysis of variance to account for interventional effects. Our intervention was based on a game-based real-time biofeedback training, and it was applied with a medical device for digital home-based back therapy. The system consists of 2 inertial measurement sensors, as well as an application-based software and a tablet or smartphone. The concept behind is that game-based exercises for movement control and stabilization of trunk muscles are performed by the patient. And with the help of the 2 sensors, the patient guides and controls an avatar via body movements through different virtual worlds. The intervention itself starts with a 1-minute trunk stabilization task while upright standing. And this was followed by a magic mirror task where the patient needs to imitate 5 given movements of the trunk and pelvis. Afterwards, the movement game for lateral reflection was followed in 3 different levels. The patient has to move an avatar with focus on lateral reflection through 3 different worlds. In total, the intervention lasted 12 minutes. Coming to the result, I first shortly mentioned that there were no carryover effects for the movement, and now I'm focusing on the presentation of the trunk kinematics, concentrating on the interventional effect. First, I present the maximum angle for the right-sided lateral trunk flexion. We also analyzed the left side, but due to presentation time, the focus is now on the right side, and there were no differences between sides. This bar graph here shows the maximum angle in comparison of pre and post intervention for all 3 segments, so the thoracic segment TS, the lumbar segment LS, and the total trunk segment TR in all 3 planes, as you can see here. And the main result is that there is no significant change from pre to post intervention for the maximum angle for both segments as well as the whole trunk. When you take a look at the lateral reflection, so the Z direction. But besides, the thoracic trunk segment showed a significant reduction of ROM, or of range of motion, for trunk extension and flexion from pre to post intervention. This you can see here, it is highlighted with the little star at the TSX bar. Taking a look at the angle reproduction, we can say that we firstly analyzed the results of the preparation trials. During the preparation trials, the target angle of 20 degrees was positioned manually by a physiotherapist by use of a handheld goniometer. And the analysis of the preparation trial shows that not always the 20 degrees of the target angle were reached. Therefore, an individual normalization to the preparation trials is the consequence for our data analysis. And therefore, we did this normalization and applied this to the data, but even though we normalized it, we found no significant change from pre to post intervention for individualized normalized angle reproduction. So there was no change from pre to post. The presented results leads us now to the summary that no intervention effect in the main movement plane could be observed during trunk motion analysis. However, the upper trunk showed a significant reduction of movement in the secondary movement plane. This might be discussed in the background of a reduced evasive motion and an increased trunk movement control in our cohort analyzed. Therefore, a game-based real-time biofeedback might be discussed as an effective tool to improve trunk movement control in patients with chronic low back pain. However, our presented results need to be interpreted with care because of the small sample size, the lack of a control group, and for sure the short intervention duration. Moreover, the integration of game-based biofeedback in therapy routines are challenges that need to be addressed in future works. And finally, I want to close my talk summarizing the key messages of our study. Although no acute intervention effect could be found for trunk motion analysis in the main movement plane, here it was lateral reflection, the changes of the secondary movement planes might indicate reduced evasive motion. And improved trunk motion control in patients with chronic low back pain might be discussed even after a single bout of a game-based real-time biofeedback training. And therefore, I'd like to thank you for your attention and apologize again for the problems at the beginning.
Okay, thank you. And in the interest of time, we will just move on to the next speaker. Next, we have Christian Rodriguez from University of Pennsylvania in the United States. So Christian, if you want to unmute, you can take the floor.
Hello, I'm Christian Rodriguez, a medical student at the University of Pennsylvania, working under the guidance of Dr. Kamran Saifi and Dr. Dennis Anderson, and I will be talking about modeling the adjacent segment biomechanics of a T10 pelvis spinal fusion. Adult spinal deformity is a spectrum of conditions that is increasingly prevalent across the world. However, when treated surgically, ASD patients are still faced with risk of postoperative complications. One such complication, proximal junctional kyphosis, has troubled surgeons over the past decades with reported complication rates ranging from 10 to 40%. The substantial complication rates of ASD correction, along with the economic and clinical burden of revision surgery, demonstrate a need to understand the mechanisms of PJK in order to develop optimal preventative measures. Despite substantial literature on PJK, the pathogenesis of the condition remains unclear. Potential mechanisms include paraspinal muscle dissection at the upper instrumented vertebra, disruption of the posterior ligamentous complex, adjacent disc degeneration, instrumentation failure at the UIV, and facet violation. The aim of this study was to investigate the biomechanical stresses adjacent to the UIV of a T10 pelvis fusion by analyzing post-fusion changes in compressive, anterior-posterior shear, and medial-lateral shear forces at the T9 vertebra in a large cohort of patient-specific models. This approach is one of the first to utilize a cohort of subject-specific models to assess PJK following surgical treatment of ASD. We utilized a publicly available dataset of 250 OpenSim subject-specific musculoskeletal models of the trunk and upper body, representing 125 men and 125 women. The subject-specific models in this dataset were created from generic, previously validated male and female musculoskeletal models that include the individual vertebra of the thoracolumbar spine, ribs, and sternum. To create the T10 pelvis fusion models, the original subject-specific models were further modified to lock the intervertebral joints from T10 to the pelvis, allowing the joints to support moments while eliminating any motion about the joints. Normal and fusion models were used to perform simulations of 4 static postures, including neutral standing and no external force, 30-degree axial twist with elbows flexed 90 degrees and 10 kilograms of weight in each hand, 30-degree trunk flexion with 5 kilograms of weight in each hand, and elbows flexed 90 degrees and pushing against a 50 Newton force in each hand. The trunk flexion and axial twist postures required different spine angles for the fused models that would allow no movement between T10 and the pelvis. Thus, 2 scenarios were examined for these postures. 1, fixing the fused levels but maintaining the same angles in unfused levels, which decrease the overall spine angles, or 2, proportionally increasing angles at unfused levels in order to maintain the same overall spine angles as the unfused models. For each subject, model type, and simulated posture, OpenSim static optimization was used to determine the pattern of muscle forces that would maintain static equilibrium at all spinal levels while also minimizing the sum of cued muscle activations. The OpenSim joint reaction analysis tool was used to compute compressive, medial lateral shear, and anterior posterior shear loads acting at the T9 vertebral body. Our analysis found that the compressive forces were higher than anterior posterior shear and medial lateral shear forces. Axial twist caused the highest compressive loads, followed by trunk flexion, then pushing a force, and finally standing. Anterior posterior shear force was anteriorly directed for axial twist and trunk flexion, and posteriorly directed for standing and pushing a force. Medial lateral shear force was only notable during axial twist. Overall, loading calculations had high variability. Differences between pre-fusion and post-fusion T9 biomechanics were consistent between maintained overall spine angle and decreased overall spine angle conditions in all relevant cases. Decreased overall spine angle results are as followed. During axial twist, compression decreased from 1,583 newtons pre-fusion to 1,170 newtons post-fusion, a 414 Newton change. Trunk flexion had a compression decrease of 153.8 newtons. Standing and pushing a force postures also saw a significant decrease in compression of 27 newtons and 109 newtons respectively. Anterior posterior shear force significantly decreased 40.7 newtons during pushing a force. During axial twist, anterior posterior shear force significantly increased 101.1 newtons from 23.16 newtons to 204.2. During trunk flexion, anterior posterior shear force significantly increased 50.3 newtons. And during medial lateral shear force significantly increased 41.1 newtons during axial twist. Medial lateral shear force during axial twist for the maintained overall spine angle condition significantly increased 119 newtons, approximately triple the increase seen in the decreased overall spine angle condition. For the other three static postures studied, changes in medial lateral shear forces were determined to be clinically insignificant due to net force changes being less than 1 Newton in magnitude. Our analysis showed that multi-level fusion used in surgery for adult spinal deformity causes an increase in shear forces and a decrease in compressive forces at the T9 vertebra. Altogether, the increased shear forces and decreased compression at the proximal adjacent segment may increase stress on the posterior ligamentous complex, facilitating the development of PJK. Although acutely there was demonstrated decreased compressive force across the vertebra overall, we predict that the chronic degeneration of the PLC, facilitated by increased shear stress, may cause patients to experience an increased bending moment with increased compression at the anterior column. This may result in vertebral fractures in severe cases, such as those involving osteoporotic bone in the chronic setting. As shown in the literature, PJK can occur up to 6 months postoperatively, so such stressors do not necessarily have to precipitate acute biomechanical changes. Despite the limitations, this computational model provides novel insight into the mechanical properties and pathogenesis of PJK. In addition, this modeling approach may be utilized in further studies to investigate different construct lengths or the impact of preoperative radiographic parameters on segment spinal biomechanics. Meanwhile, surgeons should pay close attention to preservation of the PLC and continue to utilize novel techniques to either stabilize or enhance the PLC in the effort to prevent PJK. Thank you.
Thank you, Christian. And as we're still running a bit behind schedule, I think let's just proceed to our final presentation and then open up for questions at the end. So our final presenter is John Rasmussen from Aalborg University in Denmark. And John, if you're ready, please take it away.
Thank you very much. So I'll talk about biomechanical evaluation of the effect of minimally invasive spine surgery compared with traditional approaches. And the authors, I'm the first author responsible for the model, and the last author, Sten Rasmussen, who is not related to me. He is a chief surgeon, so he is the clinician looking for answers. and Christopher and Björn in the middle, they're responsible for doing the experiment. So the questions we have here, this is rooted in the clinical question of which surgical procedure to use for fixation of fixation of joints in spine surgery. So Sten Rasmussen, the last author, is a big proponent of minimally invasive spine surgery, and there's also, of course, the traditional open spine surgery. Now, the characteristics of the first one is that when you do the traditional open spine surgery, you have to sacrifice some of the muscles in the vicinity of the fixation site. And I think the logic behind that is that if you fuse the two or more vertebrae together, then there's no more motion, and therefore you don't really need the muscles in that area. But it's a little more complicated than that, because many of the muscles cross many different joints and so on. So we can't really know what the consequence is. If we do the minimally invasive spine surgery, then we can keep all of the muscles. So we want to extend this to look at activities of daily living. So the contribution that we have is that instead of looking just at nominal motions like flexion and extension, we've performed some experiments that are doing activities of daily living. In this case, it's 3 different cases of box lifting. So this is one motivation. The other motivation is that the models keep getting better. So we have to repeat these investigations every once in a while. So we're using, for this investigation, we're using the Antibody modeling system, and the model you see here has about 1,000 different individually activated muscle units, not all of them in the spine, of course, but it's a relatively detailed model. So the combinations that we're investigating are these that you see here. We have a baseline case, so that is an able-bodied individual. So there are 3 of those lifts, so that will give us 3 cases. Then we have 5 different fusions that we're looking at: L3, L4, L4, L5, L5S1, L4S1, and L3, L5. And all of these are combined with the 2 different surgical approaches, the traditional open spine surgery and the minimally invasive surgery. And these are again combined with the 3 lifting scenarios, and that will give us another 30 cases. So we will arrive at 33 combinations of surgeries and motions. And it's a very detailed model, like I said before, so it has a lot of output, and the totality of these 33 is almost 5 gigabytes of binary numbers that we have to crunch in order to figure out what's going on. And yeah, so we'll jump right into the results. And the first results are for the sagittal plane lifts. It turns out that for the 2 lifts that happen in the sagittal plane, the results are quite the same when we look at the compression forces between the spinal vertebrae. So we're not really differentiating between them here. If we look at L5S1 compression, then you can see the curves here for the sagittal plane lift. And you can also see that all of these curves, which are representing the different compressions and the different, which are representing the different cases of baseline and minimally invasive and traditional approach spinal surgery, you can see they're quite close to each other. So there's not a lot of difference between them. And the same goes if we look at a different case of L3, L5, and actually all of the other cases as well. Like I said before, there's an enormous amount of data, so I'm really picking out typical cases here. So you can see in these sagittal plane lifts, it doesn't seem like there is a lot of difference between the loading that we see on the vertebrae in the baseline case and in the cases of the surgery, and also not between the 2 different types of surgery. It's a little bit different when we look at the sideways lift. because at the end of the sideways lift, we actually see a differentiation in the results, as you can see over here on the right-hand side. So this is for the case of L3, L5 fusion, and you can see that on this graph here, you can see that the solid lines are mainly the ones that we have here on the lower part of this section here, and these are for the baseline case, and the lines with the various kinds of dots are the ones up here, and these are for the surgical cases. And maybe I should just mention that for the surgical cases, the way it's implemented into the model is, of course, that when two or more vertebrae are fused, then they are fused, so there's no motion between them, and the necessary motion to move the entire body is then distributed among the adjacent joints in the spine. And so you can see that here in this case, it actually does seem like there is a difference between the different cases. What we cannot see here, though, is we cannot really see a lot of difference between the minimally invasive spine surgery and the traditional approach, which is actually a bit of a disappointment, I think, right now to the fourth author, because he's a big proponent of the minimally invasive surgery. However, we have only looked so far at the joint reaction forces. We have only looked at the compression forces between the joints. We have not even looked into the shear forces yet. And we have not looked at the muscle forces yet either. So there's a lot of opportunity for us to find differences in other parts of the biomechanics of the spine between the different cases, but we haven't finished that yet. So in conclusion, the sagittal lift cases, they exhibit little difference between the fused and the intact cases. And if we look carefully, we can find cases where the fused spine seems to be more loaded than the intact spine, and that would be in the case of the sideways lift. But we're not finished looking. The deadline for the real paper is not yet. So we are still looking into the data for this. So in terms of what we have found so far, I would say that the difference between the minimally invasive surgery and the traditional approach is inconclusive. We have not really seen a lot of difference between them, which is actually also something you can find in other papers who have done something similar to this. But I think there's another interesting finding that I would like to point out here. And that is the difference between the two cases here. So we in the sagittal plane case, we did not see a lot of difference. And in the sideways case, we saw more difference. So it's probably not enough if we want to evaluate these things using models. It's probably not enough to go for nominal models with nominal motions and so on. I think we need to model more cases of motions, more cases of loading, in order to get a full picture of what might be the difference between different treatment options in these cases. And the nice thing about this is that it's getting easier. So the experimental investigation that we used here did not take a very long time, because we used an IMU-based system for the motion capture. And this is one of the things that are happening technologically, that the barrier for collecting data is getting much lower. I think somebody mentioned a little bit earlier that that motion capture systems and so on are not available in typical clinical settings. And fortunately, a lot of new technology is coming out that is making this much simpler. And this is what we have drawn upon here. So I see some kind of future where we will have a library of a lot of different motions, and a library of a lot of different model sizes, and a lot of different surgical approaches and other interventions that you might think about. And then we can get a fuller picture by analyzing all of these and investigating the data. So with that, thank you very much for the attention.
Well, thank you very much, John, and to all our presenters, thank you. I think at this point we can open back up for questions for the third session, and there's a number of them in the question and answer box. So maybe I will start by bringing some of those up. And maybe I will just try to allow a few of the questioners to voice their questions. Alexander Breen, you had asked a question for Arjan. I've given you the ability to speak if you want to unmute. And while we're, okay. It's like, go ahead.
So I was just wondering, first off, just to make sure, the models that you used, they were purely just mathematical models. They weren't outcomes from real patients.
Yeah, so the geometry of the intact spine, so the vertebrae and the disc, were based on real patient data. But then we virtually operated these patients by implementing the cages.
So we know that a surgeon placing a device in is not going to be as perfect as our models. So did you investigate the effects of the positioning of those cages?
Yeah, that's a good question indeed, because we are working on that now. Because now I manually inserted the cages in a position that the surgeon confirmed, okay, they are in a realistic position. But we also have another cohort where we analyzed the CT scans of patients that were actually operated with PLIF cages. And we measured, let's say, the variance in where these cages were placed. And as you can imagine, the most variance was found in the lateral position of the two cages with respect to each other. So now we are running a sensitivity analysis in our model where we place these two PLIF cages at a different distance from each other and at a different positions with respect to the spine. And then we analyze how much the outcome at the strains of the strains at the surface will vary at these different positions. So that's what we're investigating now.
Thank you very much.
And then a follow-up, I believe, to that from Deepak Rajasekaran. If you would like to unmute, you can ask your question live.
Yeah, I also see his question in the chat. So if I'm correct, he asks how I defined the contact interaction between implant and vertebrae and whether we did a mesh convergence study. So we prescribed a hard normal contact between the cage and the end plate with a coefficient of friction of 0.2. And we did look into the influence of the mesh size of the cage on the end results. I should say that we retrieved the exact geometry of the cage by micro CT scanning the cage such that we had the exact geometry. So we didn't have a real ground truth of the design of the implant. So if we changed the exact mesh, you would also change the micro roughness that was taken into account into these models. So we did check the influence of the size of the mesh, but I wouldn't say it's a complete mesh convergence study. But if that doesn't answer your question, please let's hear of you.
Thank you, Arjan. And
thank you. Yeah, got it. Thank you so much. So you took the coefficient of friction from any literatures or from the material property, the coefficient of friction?
Yeah, so the coefficient of friction was based on a previous finite element study. So that's the only thing I can say about it, but I think it would also be interesting to vary this coefficient of friction because it might also have quite some influence on the contact behavior.
All right, thank you so much.
Okay. Thank you. Jaap, I see that you have put in a couple of questions for two of the presenters. If you would like to unmute yourself, you can ask those directly if you'd like.
I think they have been addressed in the...
Okay. Okay, then there's a question. I guess, Leonard, you had a question you wanted to ask Tito. Did you want to bring that in?
Sure, yeah. The question I had for you, Tito, was perhaps I missed it in your presentation, but did you include any EMG data to compare your muscle activations predictions to in this or prior research?
No, unfortunately, EMG data were not available because the data set that we defined was identified by a search in the picture archive system of our institute. And so we just obtain radiographic images and the information about sex, age, and the research sign that we measured. So unfortunately, we don't have this kind of data.
I'm going to take the prerogative to ask a question for Juliane on your, I guess, sort of two-part question. So your patients were just doing a lateral bending task, it seemed like. Can you comment on why you selected that and not another activity or a group, several activities, like John was saying? We might need to look at more than one thing. And I guess secondly, just to clarify, I think it seemed like your outcome was just moving sort of or to a static range of motion or a set position, like 20 degrees, I believe it was. So did you look at like their ability to perform a dynamic task and the effect on that as well?
So I start to answer maybe the first one, why we choose the lateral bending as a very simple and one plane task. In futures, in past studies, we analyzed tasks like lifting and concentrated more on the extension and flexion movement of the patients. And there we found out in our data analysis that this movement, extension flexion, is a very stable movement even in patients, and yeah, that the pattern is very stable. And during the analysis, we saw on our data that the two other planes that are helping to stabilize the motion seem to be like adjusting screws, so that we interpreted our results that the lateral reflection or the rotation could be some sort of special plane or movement plane that might be of interest for movement control. And therefore we try to focus now our task on a lateral reflection to get more to get new information on a new plane, and not only focusing on extension and flexion, because this is very well investigated. And we didn't, we want to have an easy task to have an easy setup, even though we know that it's not a functional task itself. So, or a daily, not a represent of daily living. It's just only a represent on daily living when you think about lifting a box on the side, for example, and doing a lateral bending. This is why we choose the lateral reflection. And the angle reproduction was like the 20 degree was the target angle, and now the subject had to go from the middle upright standing always to the 20 degree. And our aim was about like to see if such a short intervention can optimize the reproduction, so the sense of movement in patients. And therefore, we just took the 20 degree out of the literature-based values. And for future studies, we summarized that we want to apply or want to test in more functional situations and more daily living situations. to be more functional.
All right, thank you. I see a question for Christian in the Q&A from Hamid Parnamahai. I will try to give you the mic if you want to unmute. If he's not,
Hi.
there he is. Hello.
Hi, how are you? Thank you. Thank you for good presentation. I have a question. In order to simulate the effect of fusion, did you fix rotational DOFs or translational DOFs or both? Christian.
It was both. It was completely locked the joints in all degrees of freedom.
Oh, thank you.
All right. Any other, I see Jaap has his hand raised. Go ahead.
Yeah, there was a remaining question that I'm sorry, I forgot about. So
Okay.
the question is to Tito. The question was, you looked at the additional value of biomechanical parameters to basically geometric parameters, but I can imagine that in the situation you were modeling, these are actually quite strongly correlated, and you didn't report that as far as I recall. So I was wondering whether you did look into that.
No, we didn't report it. We actually did not calculate the correlation. We expect that there are some, and in our previous work, where we evaluated mild scoliosis as well as moderate and severe, we found that the intervertebral lateral shear was moderately to strongly correlated with the Cobb angle. But in this case, since we used classification methods that try to extract the most information by putting together all the parameters you can deal with, we preferred not to perform a priori cut of I don't know of measurement that were correlated between geometric and biomechanical. But you are correct. We expect that there are some correlations, and it is a good suggestion to refine the results in our publication.
Well, or maybe just to understand why there is no added value, that would also be helpful, I guess. I have a follow-up, if I may. And that is, did you also look at the sagittal plane shear components? Because you presented lateral. But...
Well, as regards the sagittal parameters, we looked at the thoracic kyphosis, lumbar lordosis, and the spinopelvic parameters. We accounted for the sacral slope and the pelvic incidence, and
but
also
not the shear force in the sagittal plane.
Sorry?
Not the anterior-posterior shear forces.
No. We simply looked at the lateral shear because it's expected to be the most affected by the lateral deviations in the coronal plane related to the deformity.
Thank you.
Arjan, you have your hand up.
Yeah, I also had a question for Christian. Nice talk. Maybe a little bit of practical question, but now you indeed did fix the complete, or you did fix all the vertebra included in the posterior instrumentation. Did you consider, or would it be possible in your model to partly fix these vertebrae? I know in our research group we are now focusing, or we trying to investigate whether it would be possible to, for example, semi-rigidly fix the upper instrument vertebrae to get a kind of transition zone between the fixed spine and the remaining spine that is intact. Is that possible in your models?
So because it's a static posture, I'd say no, because you would just be essentially changing the posture, but it wouldn't be like motion, you know. It's so I'd say no for how it was constructed.
Okay.
Okay, well, I appreciate that. If there are any other questions, please feel free to raise your hand. But otherwise, I think we might move to a little bit of more general discussion about what we've seen here today, and maybe a question for anyone from either from the last session or any of the presenters. Kind of going back to the points that came up earlier about standardizing our approaches, maybe standardizing the movements that we're looking at, and adding to that, you know, how we validate models, and basically the availability of a ground truth to compare our models to. This is I think kind of our biggest challenges right now in this area. So where do you see it going? What are the next steps? What are the next things that we hopefully, say, 5 years from now have overcome? And you know, what is our ideal as a field? So I don't know if anyone wants to jump in and try to answer that, or jump in and try to reframe my question in your own way. But for the last few minutes of our symposium, I think it would be a good thing to talk about. Anybody? Yeah, John, are you?
Yeah, I'm sorry. I haven't got the button to raise my hand, and I also cannot write anything in the question and answers box. so
yeah, that's a little different for the panelists versus the attendees. But
okay,
please.
So, but I can tell you what it is that we are trying. So basically, we have, for a number of years now, we have been making models of individuals, and we've tried to make them more and more individualized. And right now we're trying to make the model statistical instead. And when I say statistical, it's statistical in terms of anthropometry, and it's also statistical in terms of motions. So we're really parameterizing the motions and the anthropometry at the same time. And then we are typically, we end up with a huge amount of parameters describing a model. And then we typically apply principal component analysis or something like that, some reductional method to that, in order to get to a manageable amount of parameters. So we try to figure out statistically the correlations between the parameters so that we can use fewer parameters as input. But that's basically the way that I see it going, so that we can make virtual models that are different sizes and different motions and so on, and also have the correlations between the anthropometry and the motions and other parameters inside the models.
So Dennis, if I may follow up on that and ask a follow-up question to John. So how would you unify that then with a clinician, like in your case, who would approach you and would want answers or guidelines for a specific patient?
I think it can be, well, we haven't completely figured it out probably, but I would say that so it helps in two ways. It helps in the sense that to make statistical models, you need a lot of data collected. Okay, so we have a bigger amount of data and a bigger amount of results and so on, so we can see how things are varying. So that's one thing. The other thing is that when we have statistical models like that, we can also make them parametric. And that means we can predict some parameters based on others. So we're actually able to create models that move in a certain way and have certain characteristics based on what we call little data. So we call it the basic data that we collect in order to make the statistical model, we call them big data. And then typically in the clinical situation, you haven't got everything that's necessary to make a person-specific model, but you might have little data. So you have medical records of the patient, you know more or less the condition of the patient, you know what size, age, gender, body mass index, and other things that you can measure in an easy way. And then you seed them into the statistical model, and the statistical model comes out and says, okay, given what you have told me, I think this is more or less the kind of person and motion that you have. And of course, that's not necessarily a patient-specific model, but it gets better the more input data that you have. And it's also the best guess that anyone can make given the data that you have.
Yeah, I think this is definitely a challenge, and I think a number of us in the field are thinking in this way. But you know, I think to Leonard's point, figuring out how to kind of connect the little data to the big data. So you know, we've probably can't always get all the data for a patient. You know, either you don't have full body imaging, or you don't have motion analysis data, and you're probably never going to have that for everybody. So how do we figure out what's most important and pull it together with statistical data from large databases to tell us something clinically useful? I think that's.
So maybe I can give you an example. So we have mostly been working on running. So running is like our test case for this. So we have a lot of runners measured. And then, but in any given situation, you cannot measure a runner using a full motion capture thing, but you can put an IMU on the runner, so you can get accelerations at certain body points and so on. And there's still a lot of information in that. It's just not the full body motion, but that becomes rich little data that you can put into the model, and then you will get a model that has the same accelerations that you have modeled, and then all of the other motions are inferred from that. And it actually looks like it works quite well for repetitive motions like running, and probably also gait.
Interesting. And I once again want to thank all of our presenters throughout and all of our attendees for joining us. And I will, I think, turn it back over to Stefan for a few final closing remarks at this point. Thank you.
Thank you much, Dennis. And yeah, I'm not going to make it much longer. I would like as well, on behalf of the organizing committee, thank to all the presenters for their very nice presentations, and all the attendees for participating in our symposium. I think the peak amount of participants in total was around 120. That was like an hour ago. Now it's getting less and less, but that's normal. We're finishing up. As well, I would like to thank again to our sponsors, Frontiers, Viken, Medtronic, and the NCSRR for contributing to publication fee waivers. In total, we have, maybe to mention that as well, from Frontiers 2 full publication fee waivers, from Viken 1 full publication fee waiver, and from Medtronic and the NCSRR each half of publication fee waiver. Just before leaving, please, I hope it will pop up, the evaluation form. It's only 4 or 5 questions, and you can just click. It's multiple choice, so you don't have to write anything in. I think you can if you want, but you don't have to. And yeah, with that, oh yeah, I forgot before to not forget, just to remind you again that we're still accepting submissions until the 5th of June. So submit your papers, and we will happy to receive them. And now, thank you again. Hope to see you next time. If there is a next time, there is actually a question in the evaluation form that addresses that point. If there should be maybe a next time. And yeah, finally, we unfortunately cannot offer you a cold beverage and sit together and discuss more, but at least a little picture of it. Maybe you're going to do that now at home anyways. So thank you again, and yeah, hope to see you next time if there is one.
Bye, everyone.
Bye,
Thank you.
everyone.
Thank you. Goodbye.
Bye, and thanks for organizing.
Thank you. Bye.
Thank you. Bye.
Thanks, Stefan.